and rest. Okay, and then just kind of some general recommendations about how to optimize your sleep. So starting out with what is sleep and why do we do it? So sleep is a reversible physical and mental resting state. It's a biological requirement. We used to think that sleep is kind of a passive thing. It's a time for the brain to kind of shut off and be inactive, but we know that now that we know sleep is an active process, there's a lot of activity happening in the brain, a lot of active recovery, restoration that's important for optimal functioning in many different areas of life. Sleep deprivation in rats, it results in the rats dying if you do it for long enough. And also in humans, we know that prolonged sleep deprivation results in decreased performance and cognitive abilities. And this book on the side is a recent book that came out that I think is gives a good overview of the interesting and important things to know about sleep. I'm kind of a nerd in that way that I found this book really fascinating. So if you want to dive deeper, I think it's a good introductory kind of overview of what sleep is. The last few things on this slide. So sleep is broken up into different stages. There's different stages or types of sleep that happens throughout the night. And it's broken up into what we call non-REM sleep and REM sleep. And the REM stands for rapid eye movement. This is kind of a visual breakdown of what that looks like during the night. So majority of it is stage 2 or N2 sleep. And then a quarter, 20 to 25% is non-REM 3 sleep or stage 3 sleep. And then about a quarter is REM sleep or rapid eye movement sleep, which is typically associated with dreams. This is kind of a visual breakdown of what it looks like going through different sleep cycles during the night. And so in the early part of the night, there's more of N3 sleep and relatively little REM sleep. And during the course of the night, we get progressively more REM sleep and less N3 sleep. And different sleep stages are associated with different physiologic changes in the body. So during non-REM sleep, that's when things are kind of typically you're not dreaming, and there's some blood pressure and heart rate, breathing changes that occur specifically in that stage of sleep. So why is sleep important? I think of it as one of the 3 kind of pillars of health, along with nutrition and exercise. People will talk about often, if they've gotten lazy with their habits and they want to get healthier and they want to kind of be healthier. They talk about nutrition, going on a diet and exercising more, but less often people will talk about sleeping well. But that's just as important as those other 2. It's not a luxury to give yourself enough time. You can only sleep well on vacation or on weekends. Sleep is a necessity. It's as important as the water we drink and the air we breathe and the food we eat. And sleep is important for multiple functions, including cognition, memory, mood, physical health, cardiovascular health, mental health, all kinds of things. So it's really important. It's kind of different ideas about why we sleep and what is actually happening during sleep. Some of these are, probably all of these are true to some degree, but there's still a lot that we don't know. And the field of scientific study of sleep is still a relatively young field, only started in the 1900s. Mid to late 1900s is when we started looking in earnest about what is actually happening to the human body during sleep. And we have different needs for sleep throughout life. As newborns, newborns sleep up to 2/3 of the day, and we get progressively less need for sleep as we get older. Typically for adults, 7 to 9 hours is what's recommended. What that sleep looks like as we get older also changes. So as we get older, there's more kind of challenges that affect the quality and continuity of the sleep that we do get. And so it's important to try to do what we can to optimize the sleep that we do get, and also prioritize it and make it a priority. So as we get older, sleep phase advances. This means that the time when we feel sleepy and when we actually go to sleep typically moves earlier in the day than when we're younger. And sleep is more fragmented, disrupted at night for a variety of reasons that I'll talk about. So we typically get less sleep in any given period of sleep. And then napping can change, the sleep architecture, that's kind of the different distribution of sleep stages throughout the night, that can change. And we're more prone to a variety of sleep disorders and things that can disrupt our sleep also as we get older. So the process of sleep, what determines when we get sleepy, when we sleep, when we're awake, when we're alert. There's kind of a model of looking at two things that are happening in your body that determine when you feel sleepy, when you feel alert. And these are called process S and process C, which we'll talk about. So process S is a homeostatic sleep pressure. Basically, the longer you're awake, the more sleepy you feel. And this is because of a chemical that builds up in your brain called adenosine. If any of you drink coffee, then you're well aware of the effects of adenosine and how to counteract that. So caffeine is a chemical that is in coffee and tea and soda. It makes you feel awake and alert, and the way it does that is by blocking the signal of the adenosine that builds up in the brain. So it kind of blocks the sleepiness signal that is building up throughout the day. So this pressure to sleep sort of builds up throughout the day from the time that you wake up and goes down when you're asleep. So that's when the adenosine is kind of cleared from the brain. You can think of it as kind of like a pressure cooker. So the pressure starts building up from the time you wake up, and when you go to sleep, it kind of releases that pressure. The next slide is process C. So this is the circadian rhythm that you may have heard about. This is our body clock. The timing of the sort of the peaks and valleys of when we feel alert and when we feel sleepy are influenced by a variety of things. But this is kind of our body's timekeeping mechanism, our body clock. And oops. Okay, there we go. So just to say a little bit about circadian rhythm. So these are processes in the body that are based on the changes in our environment that we sort of evolved with. The Earth is rotating every 24 hours. We have a day-night cycle, and that's kind of what that part of our human physiology, our biology is based on, that changing environment. And so it kind of helps to coordinate different body processes to happen at different times. And a large part of this is based on the changes in the environment, specifically the light and temperature are big factors. So these two processes, C and S, have to be synchronized in order to facilitate normal sleep and regulate sleep properly. And these can become misaligned. So for example, if someone's working a night shift, then you're tending to be awake when your body thinks you should be asleep, and you're trying to sleep during the day when your body wants you to be awake. And this can cause other kinds of problems. So we'll talk a little bit more about that. And so yeah, this is your circadian biological clock. This is your body's way of keeping time. And this is, I like this diagram just because it kind of demonstrates that there's a lot of moving parts here. There's a lot of different factors that can affect when you are asleep, when you're awake, and how this interacts with your health. And so the environment, there's light and temperature, time of the day, there's your social timings of when you have to go to work, when you have to be at school. If you're traveling across multiple time zones, you have a newborn child at home that's waking you up in the middle of the night. So just because your body thinks you should be asleep or awake at a certain time doesn't mean that you will, because there's a lot of other competing factors. So we talked about that. And sleep, REM sleep function, we can skip over that, I think, for time. And then, so if our sleep is disrupted, there's sort of changes that you can expect to happen when you're recovering from sleep. So some of this comes into play if you have a sleep disorder that's undiagnosed, untreated, and then eventually you start getting treated for it, and then you kind of start seeing some changes in your sleep, and hopefully for the better. So kind of the summary of that first part of the talk is that sleep is a basic biological need, essential for health. It's important for performance, safety, and quality of life. And your sleep needs change throughout life. And there's different sleep cycles that are important for different functions, and they have different consequences if they're disrupted in different ways. So getting on to the common sleep problems in MSA, we'll start with fatigue and hypersomnia, or excessive sleepiness, or excessive sleeping during the day. Parasomnia is the most common. Those parasomnias are abnormal sleep behaviors. This is like sleepwalking, sleep talking, sleep eating, other things. But the most kind of pertinent one in MSA, or most probably well known, is REM sleep behavior disorder, which we'll talk about. And then there's sleep disordered breathing, breathing disruption or breathing problems during sleep, nocturia, which is nighttime urination, circadian rhythm disorders, and restless leg syndrome. So I wanted to start with fatigue because this can be kind of a final common pathway among many sleep disorders and other issues that can affect sleep. So fatigue, we all know what fatigue is. It's a just overwhelming sense of tiredness, exhaustion. This is progressively can get worse typically does progressively get worse in MSA, and can make everyday tasks challenging. This kind of distinction between primary and secondary is somewhat arbitrary and not very straightforward, but it's just kind of helpful to break it into different categories to understand what are things that are sort of in our control to change and improve, and what's kind of what do we have to learn to live with and work around as best we can. So primary fatigue is directly related to MSA. Secondary fatigue is fatigue due to other treatable causes, and these are have a complicated interaction and multiple factors that can affect each of these. So I like this diagram to kind of outline and demonstrate. This is from a paper on Parkinson's disease, which is not MSA, but there's a lot of overlapping issues. So sleep disruption can be a cause and a result of multiple things going wrong in the body. So there's degeneration in the brain and the nerve cells kind of wearing out prematurely. This can be a result or a cause of disrupted sleep. Some of the medications that are prescribed can promote sleepiness or disrupt sleep in different ways. This has a complicated interaction with our mood. Depression and anxiety, we know, have something to do with how people sleep, how well they sleep, how tired they feel, and all these sorts of things. So it's not a straightforward picture, but it's helpful to keep in mind. So primary fatigue, these are things directly related to MSA. Oftentimes, I've heard patients tell me that I feel much more tired when it's hot, like during the summertime or I'm outdoors. Fatigue related to being in a hot environment or weather. Orthostatic hypotension, so being upright with lower blood pressure, this can also cause fatigue. And then there's just the degenerative process in the brain that's happening in parts of the brain that are important for promoting wakefulness. So the picture on the top here is what we call the hot cross bun sign. That's just a picture on an MRI where part of the brain stem called the pons is kind of degenerating or wearing out. And the bottom picture is one of the systems that are involved in promoting wakefulness. And that's an area where the brain is degenerating, and sometimes these pathways or these systems in the brain that promote wakefulness are disrupted by the disease itself. And then secondary fatigue, again, these are things that are not necessarily directly related to MSA, but kind of interact and overlap in different ways that are not always very straightforward. And so these are all things to keep in mind and ask your doctors about and pay attention to, and see kind of what are factors in your case potentially. So mood, we know from studies on depression that fatigue and poor sleep often occur with depression. So, depression is not uncommon in many people, including an MSA. So talking to your doctor, seeing if this is something that's going on, and finding out what we can do about it, either seeing a therapist or psychiatrist, that can be helpful in kind of managing that aspect of it. Anxiety can contribute to poor sleep quality and drive fatigue as well. Nutrition and hydration. So we kind of talked about being in the heat and orthostatic hypotension. So hydration is an important part of it, and multiple factors can affect inadequate nutrition and hydration. So if you're having swallowing difficulty, weight loss, seeing a speech therapist or a dietitian can be helpful to kind of maximize this aspect of your health. Environment, so temperature, lighting, we kind of talked about. Having a physically demanding home environment to navigate, that can be taxing as well. So, reducing clutter and kind of making things as easy as possible at home will prevent you from having to kind of overexert yourself. Pain can interact with sleep and exercise and cause fatigue can cause unrestful sleep disruption as well. So having pain adequately treated is also important. And then activity levels, just doing things during the day, having the right amount of activity, giving yourself enough time to rest in between. So physical, cognitive, social activities, all of these things can be taxing and can require energy. And then there's other medical things. If you have hypothyroidism, if you have anemia, if you have an infection, all these things can make you more prone to feeling tiredness or fatigue. And then one thing, so just to talk about some of the things that can contribute to fatigue. So time of the day, there's on that circadian rhythm picture I showed a while back, there's kind of the ups and downs that happen through the day. One time of the day where there is a dip in your alertness, this is kind of programmed into your circadian rhythm, is the mid-afternoon dip. And a lot of times people think of this as like after lunch, after I eat a big meal with a bunch of carbohydrates or things like that. That's when I feel sleepy. It's because if I avoid carbohydrates, then maybe I can avoid that slump in the afternoon. But it's actually probably more to do with this circadian rhythm dip in alertness that occurs in between mid-afternoon 2 to 5 p.m. There are other dips in your circadian alertness that kind of more coincide with being asleep. So midnight to 2 a.m. and then 2 a.m. to 6 a.m. is when the biggest dip. You're least likely to be awake. But of course, these things can be overcome if you have a good enough reason. If you're motivated to stay up all night to study for a test, or go to a party, or whatever else that is appealing to you, that can kind of override this drive to sleep. The more time that you spend awake, the more fatigued you'll feel. That kind of goes back to that sleep pressure. So the pressure starts building from the time you wake up. The longer you're awake, the higher the pressure is. And then time on task. Try to not have a monotonous day. Break your day up into different chunks and do different things at different times, so that you're not spending too long on any one thing. Give yourself some breaks. And then moving on to the sleep disorders and how they kind of can contribute. So fatigue, that was kind of the final common pathway. A lot of different things can contribute to fatigue. We'll talk about specific sleep disorders now. So REM sleep behavior disorder, or RBD, is something many of you are probably familiar with. This is so normally during REM sleep, the body is paralyzed, and this is like a normal part of what happens during REM sleep. This is to prevent the body movement signals that are happening in the brain from reaching the muscles, so that you don't act out your dreams and cause problems. And the part of your brain that's responsible for this normal paralysis is thought to be damaged in MSA. So this leads to body movement signals that are happening in the brain while you're dreaming. Those signals, instead of being blocked, are continuing on to your muscles, and that's what's causing the body movements and dream enactment and vocalizations, talking, and all these things people notice during sleep. This symptom or problem can often precede the other symptoms of MSA by several years. So it's often like a precursor and kind of a warning sign. Majority of MSA patients have RBD in some studies of up to 70 to 90%. So it's very common in MSA. And it wouldn't be so much of a problem if it wasn't the main thing is it's a safety concern. Most patients with MSA, or many patients, don't even realize that they're doing this because they're asleep and they're dreaming. It's the spouse or the bed partner or someone that lives with the patient that's noticing these things, and they're the ones being disrupted and bothered. And so that they're usually the ones to bring it to at the attention of the doctor. But sometimes it can lead to injuries, either to the patient or to the bed partner, falling out of bed, bruising, punching, kicking, hitting the wall, breaking fingers and toes. These are things you want to avoid as best you can. So safety is a big thing that will, if this is happening, we'll want to ask and know about safety of the bed environment. Is it?
Yeah, you have a railing there. That's good.
Mm-hmm. Yeah, just wanted to mention one kind of story that is worth mentioning, that if you sleep with weapons by your bed, there's a story of like one patient who was like a retired police officer or something, and he slept with a gun near his bed or on his bed head nightstand or something like that. And he had REM sleep behavior disorder, and he woke up one morning with a bullet hole on his ceiling. And said, well, how did that get there? And it turns out he was, acting out his dreams. And typically, if people are having bad dreams and they're fighting somebody, then, as a cop, maybe you have that's kind of second nature to reach for a weapon and protect yourself and do what you got to do. But so if you have MSA, if you have REM sleep behavior disorder, just safety is the biggest thing. And so the way we diagnose REM sleep behavior disorder is often by history or with a sleep study or both. And sleep study typically involves going to the sleep lab, getting it. So it's like a normal, overnight sleep study in the sleep lab. They kind of wire you up from head to toe, and they monitor your sleep, your breathing, your brain waves, and they take a video and kind of see what's happening at different times during the night. And then the way that we treat REM sleep behavior disorder. So number one, if it's causing problems, if it's not causing problems, we don't necessarily have to do anything about it. But if it is causing problems, leading to injuries or disrupting sleep in other ways, then we can treat with things like melatonin or clonazepam or other benzodiazepines, which are type of medication that can suppress this kind of a problem. And there is a kind of going back to one of the earlier pictures, there is a complicated interaction between RBD and other symptoms. So if you have untreated sleep apnea, that can worsen REM sleep behavior disorder. Sometimes treating the sleep apnea can improve the RBD, as well as help you feel kind of like you're sleeping better and getting better sleep. So that's a good kind of transition to sleep-related breathing disorders. The main one people are familiar with probably is sleep apnea, but in MSA specifically, there's something called stridor, and how this interacts with other sleep disorders, and we'll talk about some of the treatments as well. So sleep apnea means lack of breathing during sleep. There's kind of two main types of sleep apnea. One is obstructive sleep apnea, the other is central sleep apnea. Obstructive is the more common one in the general population, and this is typically you associate this with snoring and gasping, choking, and this is due to obstruction of the airway. So the airway kind of collapses, as seen in the picture on the right side. So the top is normal breathing, kind of air moving easily through the nose into the airway. Partial obstruction, which you see in snoring, is the airway is not completely blocked, but it's partially blocked, and air is kind of slipping through, and that results in a vibration in the airway and in the back of the throat, which results in the snoring. And obstructive sleep apnea is complete obstruction of the airway for periods of time, usually a few seconds up to a minute or longer, believe it or not. So this leads to all kinds of problems. and one of which is unrefreshing sleep, but there's other can lead to cardiovascular, cognitive issues. So this is a treatable disorder, and it's worth looking into if you have symptoms related, like the snoring, or feel like you just don't get good sleep. So it's something worth asking your doctor about. Central sleep apnea is the other kind of sleep apnea. It's less common, but it also is seen in MSA. This kind of sleep apnea is basically the signal from the brain to the breathing muscles is not going through or not getting sent. Some people say it's like my brain is forgetting to tell my body to breathe, and that's a good way to put it. So your airway is open, but it's just you're not getting a signal to activate the breathing muscles. So sleep apnea, it disrupts sleep. It results in daytime sleepiness, dry mouth, headache, and can also worsen nighttime urination. Sort of the ways that we treat it, going from the left to the right. So sleep apnea or CPAP machines are kind of the thing that people are probably most familiar with. Oftentimes people think, oh, I'm not going to be able to sleep with something like this kind of scuba gear. It's strapped to my face while I'm asleep. But people can adapt pretty well, surprising, sometimes to their own surprise. And they feel once they start using it, oftentimes they feel like they're sleeping much better, and they don't want to sleep without it after, once they get used to it. And I've shown two pictures. There's like kind of different types of masks available. There's bigger ones, there's smaller ones, there's ones that attach on the front, there's ones that attach on the top of the head. So those are, and there's all different kinds of, there's CPAP, which is a continuous one level of pressure, constantly blowing air during the night. There's BiPAP, which is a different pressure when you're breathing in, a lower pressure when you're breathing out. And then there's more kind of fancy machines that, if you have central sleep apnea, then your brain is not sending the signal to breathe, so the machine will kind of detect that and give you a breath whenever your brain forgets to. If let's say CPAP or BiPAP, the mask is not an option, it's not working, you don't think you'll be able to tolerate it, or there's just a lot of other challenges that you just can't deal with it. On the top right is a picture of an oral appliance. This is another type of treatment for obstructive sleep apnea that basically holds your lower jaw a little bit forward and keeps it out of your airway. So the main problem in obstructive sleep apnea is your tongue, your throat, back of the throat muscles become relaxed, just like the rest of your muscles during sleep, and they kind of fall back into your throat and block your airway. So, and the tongue is the main kind of problem area. So this kind of a device that's made by a dentist, custom fit for you, kind of holds your lower jaw forward and keeps your tongue from obstructing your airway. So that would be another option for people that have obstructive sleep apnea if they can't tolerate CPAP. So, and I mention this because sleep apnea does, untreated sleep apnea, it kind of goes back to this idea that there's kind of a feedback loop or a cycle of untreated sleep apnea can potentially worsen or accelerate neurodegeneration or kind of wearing out of the nerves, as seen in MSA. So it is a treatable, sleep apnea is a treatable condition, and it can potentially improve or definitely improve your quality of life, but could also potentially prolong the duration of your life. And then stridor is another kind of a sleep breathing disorder, typically characterized by abnormal high-pitched breathing sound, usually while breathing in. It's the area of the obstruction is a little bit different than in run-of-the-mill obstructive sleep apnea, where it's not the tongue in the upper airway that's kind of blocking the airway, it's the vocal cords that are not working properly. It's the vocal cords can be kind of stiff or rigid or even weak or paralyzed, and these can cause obstruction in the airway. oftentimes useful to get an evaluation from an ENT doctor to see if this is actually going on. They may, it's an area of active investigation to see kind of what can be done about this. Sometimes they'll be able, if it's a tight kind of tight, rigid vocal cord, they can put some medication or some injections to loosen or relieve some of that tightness. PAP therapy, which is like CPAP or BiPAP, sometimes that can be helpful in improving breathing as well, but this is also kind of in question right now, that there may be increased risk of causing worsening spasm of the vocal cords and potentially worsening the obstruction in some cases. So this is still not exactly clear, but something that is being looked into. Another sleep issue in MSA is nocturia, or nighttime urination. So there's multiple factors contributing to this. This can often be a very, very bothersome issue. People having to wake up multiple times during the night to go to the bathroom. Combine that with difficulty with mobility, balance, getting around, being upright. And it can make, happening multiple times during the night, this can be very challenging to deal with and results in unrestful sleep. So one of the things that even in patients without without MSA, if you have sleep apnea, those patients also have increased nighttime urination. And the thought is that the brain kind of gets a panic signal of an adrenaline rush when you stop breathing. And that's meant to kind of wake you up so that you start breathing again. And that adrenaline rush also kind of increases your blood pressure, increases blood flow to the kidneys, and that makes you make more urine. And so in MSA, that's made worse by the fact that when, we know when you stand up, your blood pressures can go low and cause problems, but when you're laying down, it also, blood pressure can be high, and that has other sets of problems. One of which is increased blood pressure when you're laying down, like when you're sleeping, can increase blood flow to the kidneys and result in this frequent urination at night. So multiple reasons why it is recommended for patients with MSA or autonomic failure to sleep on an incline, one of which is to reduce the nighttime urination. The other is to reduce the blood pressure while you're lying down. So it's kind of a two-pronged or multiple reasons to try to sleep on an incline. Other things you can do to reduce the nighttime urination: reduce the amount of water you're drinking immediately before bed, or like in the few hours before bedtime. Try to front load your water starting when you wake up in the morning, and then gradually less and less as you get closer to bedtime. I mentioned, sort of the connection with untreated obstructive sleep apnea and how that can contribute to nighttime urination. So if you have sleep apnea, it's also would be a benefit to treat it. And then medications, there are potentially medications that could be helpful for this problem as well. Restless leg syndrome. So this is something people have probably heard about and kind of seen commercials for on TV, and I think, oh, that's probably not a real thing, but it is a real thing. It was first described, in the 1600s, and kind of more in the recent years, in the last century, it's kind of been better characterized in the modern sense. So restless leg syndrome is the prime symptom is restlessness or discomfort in the legs, urge to move. It doesn't have to be in the legs. In up to 50% of patients, it can occur in the arms, but usually will start in the legs. So it's not just kind of an urge to move, but can be unusual sensations that accompany that as well. Sometimes people describe it as like uncomfortable, creepy crawly, like an internal itch, or kind of shock-like electrical sensations. Sometimes this can overlap with, can be difficult to distinguish from a neuropathy, but it's not always clear, but there are things that we can try to either way help with whatever's causing these problems. So it typically is worse during periods of rest or lack of activity. So if you're sitting in usually laying in bed is kind of a classic provoking situation, but it can be, you know, being in a car for a long time, going on a long road trip, or sitting in an office chair, just being kind of fidgety during the day. It's typically relieved. You know, people that have this at night, they'll typically say, you know, I have to like move my legs around, or I get up and stretch, or, you know, walk around the house for a little bit, and that will usually help until it can kind of subside or find a way to get to sleep eventually. Oftentimes there's a family history, but not always. And we'll talk about treatments in the next slide. And typically it's a time of the day that is one of the features of it. So things that can worsen restless legs, certain kinds of medications. So tricyclics, a type of antidepressants, which typically I don't think, probably wouldn't have MSA patients on this kind of a medication. But there are, you know, just certain medications to be aware of that can worsen restless legs. And so the way that we treat it, we can check an iron level. So if you have a low iron, that can kind of trigger or provoke restless legs. So if you have low iron, we can give you supplementation or just try to bring your iron levels up. If that's not enough, then gabapentin or dopamine drugs like ropinirole, pramipexole, not so much. There's other Parkinson's medications that oftentimes can help with the symptoms in the short term, but they're so Parkinson's-like medications, and then opioids and benzodiazepines, which are often used for other sleep disorders like REM behavior disorder. And then one thing to be aware of in restless legs is that symptoms can get worse with treatment, and you can over-treat, and you have to kind of dial back and just be aware that if you do start treatment with dopamine drugs for restless legs, you kind of have to find the sweet spot, because if you go too far, then it can worsen your symptoms and you have to kind of dial it back. So just something to be aware of if you do have restless legs and your doctor puts you on medication for it, and symptoms seem to get worse, then you may have gone too far. And then I wanted to talk about, so it was kind of, should have had a summary slide, but I talked about kind of the basics of sleep, what is involved, how it works, and what are the common sleep issues in MSA. Not everything is going to be fixable, unfortunately, and kind of working to optimize what we can. So there are certain things we have treatments for. Sometimes the best treatment is behavioral rather than medications or a device or some new invention. It's just, you know, doing the best you can to structure your life in a way that helps promote good, healthy sleep. I like to tell my patients that sleep is not like a light switch you can turn on and off. You have to set the conditions for good sleep by doing the right things during the day. So a routine is key. So before you get into bed, having a routine around your sleep and wake and in your day is helpful for so many reasons, but in sleep particular, it's really important. So before bed, getting into reducing sort of the just turning off half the lights in your house at the hour before bedtime, turning the temperature down a little bit, especially in the summertime, that can help you to fall asleep. Avoiding screens, you know, I think we're all probably guilty of it to some degree, is being on our phones and devices at times when we probably shouldn't be, but just trying to be more aware of that and limiting that in the hour or two before bedtime. Avoiding caffeine, alcohol, tobacco, and even exercise before bed. All of these things can kind of wake you up and prevent you from getting as good quality sleep. And then you should try to incorporate, you know, at some point growing up, we stop having like bedtime routines and, you know, reading a story, and we do that for kids, but at some point as an adult, we just stop doing that. But it's still a good idea to have some kind of a wind down routine. whatever it may be. So meditation, relaxation, deep breathing exercises, or reading a book in dim light, all those things can be helpful. Once you're in bed, don't watch the clock. If you're somebody that has trouble falling asleep, don't lay in bed for more than 20, 30 minutes if you're having trouble. If you're able to get up out of bed and kind of do something else, and don't go to bed until you feel sleepy. In the morning, use the wake up time as kind of your anchor for your body clock. So wake up at the same time every day as best you can, even on weekends. One of the first things you should do in the morning is get outside, get some sunlight, even if it's, for a few minutes, 5 minutes, 10 minutes. I know that can be hard, especially in the summertime, but a lot of MSA patients I saw last year and including this year, they just have very limited mobility. They're not able to get around, and being outside on a hot day is really tough. If that's the case, then being by a window, preferably an open window. Sunlight through a window is not the same as sunlight outdoors, and it doesn't have the same effect on your eyes and setting your body clock. So that's a good habit to kind of keep your circadian rhythm and clock in alignment, and just trying to optimize your sleep as best as possible. If you do nap during the day, try to keep them relatively short, just to avoid disrupting your nighttime sleep, and then avoiding caffeine after 2 p.m. And in general, like 8 to 10 hours, sometime before whenever your bedtime is a good rule of thumb. So I could probably talk for a little bit longer, but I think I'm out of time. So I want to